Hey everyone, welcome back to Medician, your trusted medical information channel. I'm Dr. Lin, a board-certified allergist and immunologist. Today, we're talking about one of the most common and impactful seasonal allergies, grass pollen allergy. For many people, it's far more than just a few sneezes. It can mean weeks or even months of nasal congestion, runny nose, and itchy watery eyes that interfere with sleep, school, work, and daily life. Grass pollen season typically peaks from spring through early summer, but in warmer regions, it can last much longer. With ongoing climate change and extended growing seasons, pollen exposure has become more intense and prolonged. In the United States, an estimated 10 to 30% of both children and adults are affected by grass pollen allergy. Oralair offers a different approach compared with traditional medications like antihistamines and nasal sprays. It is an FDA-approved sublingual immunotherapy tablet designed not only to relieve symptoms, but to retrain the immune system. The goal is to reduce sensitivity to grass pollen and build immune tolerance. In a previous episode, I covered GrassTag, another sublingual immunotherapy option made from a single grass pollen that cross-reacts with many other grasses. But today, we'll focus on Oralair, which is formulated from a mixture of 5 common grass pollens. So, what should you know about Oralair? In this episode, I will walk you through 5 key things: its indication, how it works, how to take it, important warnings and precautions, and its safety profile. If you're new here, don't forget to subscribe for more science-based medical updates. Now, let's dive in. First, what exactly is Oralair and who it's for? Oralair is a standardized sublingual allergen immunotherapy tablet made from a mix of 5 grass pollen extracts: sweet kernel, orchard, perennial rye, timothy, and Kentucky bluegrass. It is FDA approved for the treatment of grass pollen-induced allergic rhinitis, with or without conjunctivitis, in patients ages 5 through 65. Before starting Oralair, patients must have confirmed grass pollen allergy to any of the 5 grass species contained in this product, either by skin testing or blood testing that detects pollen-specific IgE. Oralair was first approved in April 2014 for patients 10 through 65 years of age, with extended approval in November 2018 to include children as young as 5, extending this disease-modifying option to younger patients. Second, how does Oralair work? Grass allergy begins when the immune system mistakenly identifies grass pollen as harmful. This leads to the production of IgE antibodies and creates an allergic memory. With subsequent exposure, grass pollen allergens bind to IgE on mast cells, triggering the release of histamine and other inflammatory mediators that cause classic allergy symptoms. Oralair, a form of allergen immunotherapy, works through a process called allergy desensitization. Instead of treating symptoms after they occur, it delivers controlled daily doses of grass pollen allergen under the tongue. There, specialized immune cells capture and process the allergen and retrain the immune system to respond differently. With repeated exposure, reactivity to grass pollen decreases while tolerance increases. Clinically, this translates to fewer symptoms and reduced need for traditional allergy medications. It is important to remember that Oralair is not for immediate symptom relief. It is a disease-modifying therapy designed to change how the immune system responds to grass pollen. Third, let's talk about dosing and administration. Oralair is taken once daily as a sublingual tablet. For adults ages 18 through 65, the dose is 300 IR daily. For children and adolescents ages 5 through 17, the dose is gradually increased over the first 3 days to reach 300 IR daily. Treatment should start 4 months before the expected onset of each grass pollen season and continue throughout the season. The tablet should be removed from the blister pack with dry hands and placed directly under the tongue, where it dissolves completely. Do not take Oralair with food or beverage. Patients should avoid swallowing for at least 1 minute and avoid eating or drinking for 5 minutes after taking Oralair. Hands should be washed after handling the tablet. The first dose must be administered in a healthcare setting under the supervision of a physician experienced in the diagnosis and treatment of severe allergic reactions, with at least 30 minutes of observation. If tolerated, subsequent doses can be taken at home. In children, dosing should always be supervised by an adult. If a dose is missed, do not take a double dose. Take the next dose at your normal schedule time the next day. If more than 1 dose is missed, patients should contact their allergy specialist before restarting. Because of the risk of severe allergic reactions, all patients taking Oralair must be prescribed an epinephrine product and trained along with caregivers when appropriate on when and how to use it. Fourth, let's review the warnings and precautions. As an allergen immunotherapy, Oralair can cause serious systemic allergic reactions, including anaphylaxis. Severe local reactions involving the mouth or throat can also occur and, in rare cases, may compromise the airway. Although uncommon, these reactions may be life-threatening. Patients should stop Oralair and get medical care right away if they develop symptoms such as difficulty breathing, throat tightness or swelling, trouble swallowing or speaking, dizziness, fainting, rapid or weak heartbeat, severe stomach cramps or pain, vomiting, diarrhea, severe flushing, or itching of the skin. Persistent or worsening mouth or throat symptoms should also prompt drug discontinuation and clinical evaluation. Because of this risk, all patients must have access to an epinephrine product and know exactly when and how to use it. If epinephrine is used, patients should seek immediate medical attention and stop Oralair until further assessment. Patients with a history of any severe local reaction to sublingual immunotherapy or any severe systemic allergic reaction should not take Oralair. Furthermore, Oralair may not be appropriate for patients with markedly reduced lung function, severe nasal disorders, or significant cardiovascular diseases, including recent heart attack, unstable coronary disease, uncontrolled hypertension, or serious heart rhythm problem. These conditions may increase risk during a severe allergic reaction or limit the safe use of epinephrine. Patients taking medications that interfere with epinephrine may not be good candidates as well. Eosinophilic esophagitis is another important consideration that has been associated with sublingual immunotherapy. Oralair is contraindicated in patients with a history of eosinophilic esophagitis. If patients develop persistent swallowing difficulty or chest pain, Oralair should be stopped and further evaluation pursued. Asthma control is also critical. Oralair should not be taken during an acute asthma exacerbation. And patients with severe, unstable, or uncontrolled asthma should not start therapy. If asthma worsens during treatment, Oralair should be stopped and reassessed. Lastly, Oralair should be paused in the presence of active oral inflammation or oral wounds, such as ulcers, infection, cuts, or following dental procedures, until the mouth has fully healed. And finally, let's review side effects and safety. In adults, the most common side effects reported in clinical trials were local reactions involving the mouth, throat, and ears. This included mouth, tongue, or ear itching, mouth swelling, throat irritation, cough, and pain in the mouth or throat. Serious allergic reactions were uncommon, but have been reported. In adult clinical trials, 2 patients experienced serious events considered definitely related to treatment. One with rapid onset of severe coughing and shortness of breath, and another with severe throat swelling, both of which resolved with appropriate medical care. In clinical trials involving children and adolescents ages 5 to 17, the safety profile is generally similar to adults, with additional adverse events such as tonsil inflammation and asthma-related symptoms reported. Serious allergic reactions in pediatric patients are also rare. In clinical trials, 2 cases were reported. An 8-year-old developed multiple allergy symptoms shortly after dosing, which resolved with treatment, and the patient continued Oralair. The other, a 6-year-old, developed severe lip, eye, and eyelid swelling, which resolved after treatment, and Oralair was discontinued. Post-marketing experience with Oralair has included additional reports of mild to severe local and systemic adverse events. Because these events are reported voluntarily from a population of uncertain size, it is difficult to estimate how often they occur or establish a causal relationship to drug exposure. However, they reinforce an important point. Any new persistent or worsening symptoms, especially involving the mouth, throat, swallowing, or breathing, should prompt stopping the medication and consulting the prescribing doctor. Overall, Oralair has a well-defined safety profile. Most reactions are mild to moderate, occur early and locally, and often resolve within the first week of treatment, while serious reactions remain uncommon. And there you have it, 5 key things to know about Oralair. A sublingual immunotherapy tablet designed to treat grass pollen allergy by building immune tolerance and modifying allergic disease. With this episode, we've now covered all 4 FDA-approved sublingual allergen immunotherapy tablets: Odactra for house dust mites, Regretag for short ragweed, and both GrassTag and Oralair for grass pollen allergy. With appropriate patient selection, access to epinephrine, and proper clinical monitoring, these therapies can be used safely and effectively. If you found this video helpful, don't forget to like, subscribe, and share your thoughts or experiences in the comments below. Thanks for watching, and stay tuned for more evidence-based insights right here on Medician. See you next time.